So I'm happy to introduce myself. I'm Bruce Shackman. I'm a professor at Weill Cornell Medicine and principal investigator of CHERISH. And Natasha, you want to introduce yourself?
Hi, I'm Natasha Martin, professor at UC San Diego, and I am co-organizing this with Bruce. Nice to see everybody.
So I want to thank our organizing committee, which includes Natasha and myself, as well as Ben Linus, professor at Boston Medical Center, and Ahmed Bayoumi, professor at the University of Toronto, and also say that we as a group obtained a lot of input from colleagues at UCSD, including especially Anik Borquez, colleagues in British Columbia, including Boudin Nozick and others, and a variety of individuals working with people who use drugs in the US, in Mexico, and Canada. And you'll see in a moment that one of our sessions includes a discussion about how we as researchers can better involve people with lived experience. And so we're hoping, we as organizers are hoping to learn from that and profit from it as we organize subsequent meetings in the following years. So I'm just going to do a little bit of advertising for CHERISH. Next slide. CHERISH is a NIDA-funded center focusing on developing and disseminating health economic research on healthcare utilization, health outcomes, and health-related behaviors that inform substance use disorder treatment policy in HCV and HIV care people who use substances. We are a group of researchers located at Weill Cornell Medicine, Boston Medical Center, Boston University School of Public Health, University of Pennsylvania Leonard Davis Institute of Health Economics, and University of Miami Miller School of Medicine. Next slide. We offer a variety of services, including training sessions, both virtual and hopefully in the future in person, as well as training modules on our website. We offer a consultation service. So if you feel like you need input or help for either developing a proposal, a grant proposal, reviewing a manuscript, other opportunities related to health economic evaluation of substance use and HIV and Hep C related to substance use, you can receive up to 6 hours of free consultation, and you can apply for that on our website. And then our website includes also a variety of resources. And we also have a pilot grant program that you can find out about on our website. So next slide. So please do connect with us. And I'm going to turn it over to Natasha at this point.
Great. So the Opioid Use Disorder Modeling Consortium is an informal collaboration, and we have a few aims. The main goal is to strengthen ties between modelers and policymakers. Our first aim is to bring together researchers and policy stakeholders working in simulation modeling relevant to the North American opioid crisis, with a focus on overdose prevention, hepatitis C, and HIV and other syndemics. And our second aim is to foster relationships between research and government to inform opioid policymaking. Next slide. So thank you for joining us today. We have a really fantastic program. The program incorporates several panels of experts who will discuss their work happening on the ground across North America. I'm really pleased with the international representation we've been able to showcase today, with representatives from British Columbia, Toronto, Montreal, Mexico City, New York. We really cover Canada, Canada, the US, as well as Mexico. The first session will focus on addressing public health data gaps. And what I'll do is I'll just run through the sessions and I'll introduce the chairs, and then each of the chairs can, within their session, introduce the panelists. So the first session on public health data gaps will be chaired by Dr. Eli Rosenberg. Dr. Rosenberg is an associate professor in the Department of Epidemiology and Biostatistics at the University of Albany. And his current primary appointment is the Deputy Director for Science in the Office of Public Health at the New York State Department of Health. So really bringing that public health lens, which is nice. The second session will focus on engaging people with lived experiences and discussing best practices of that. It will be chaired by Dr. Ahmed Bayoumi. Dr. Bayoumi is, as you already heard, a professor in the University of Toronto's Department of Medicine and the Institute of Health Policy Management and Evaluation. And lastly, we will close our discussion with our third session, How Can Models Inform Overdose Prevention in Criminal Justice Settings? And that session will be chaired by Dr. Sarah Larney. Dr. Larney is an assistant professor at the University of Montreal and also holds joint positions at the National Drug and Alcohol Research Centre at the University of New South Wales, as well as Brown University. It's on addressing public health data gaps. And as I mentioned, it will be chaired by Dr. Eli Rosenberg. So Dr. Rosenberg, welcome and take it away. Thanks for joining us.
Thanks for having me. So I'm really pleased to chair this session. We have three really great panelists. And I thought maybe I'll do is I'll set the table a little bit, but really they're gonna do all the hard work. And in thinking through in our discussions with the CHERISH team and the consortium team sort of about how to put this session together, we really focused on two quantities that are of course very that are very important in the work we do, and those really relate to both the population sizes of persons who use substances, and then also overdoses as an important event to track. And so those are sort of two key data elements that will be part of the discussion today. And we're really going to hear from users of these data in important ways. And I thought what I would do is just sort of give a very quick rundown, I think, of ideas and concepts and methods and sources that are well known to some, but maybe not to all. And I think we'll hear some of these come up in the discussion today from our presenters. And that is just to run through, when we talk about overdose, there's some key sort of event-based surveillance sources that we turn to. When we think of overdose events, we might look at sources from emergency departments or emergency medical services reported through various systems, overdose deaths through vital statistics. But when we think about other ways to get at this information and also perhaps think about how, population sizes, one key source we've turned to over time is household and targeted surveys. So, household surveys such as the NHANES or the National Survey on Drug Use and Health, can provide wide geographic estimates, but there's key biases that I'm sure many are aware of in terms of who is included and how those data are collected through various interview practices. Targeted surveys can help address these in certain communities, but still other biases can remain. So to deal with that, we've sometimes have turned to other methodologies, multiplier and scale-up methods that might take survey or surveillance data or literature sources to try to come up with estimates that are less directly probed in those surveys. So multiplier methods might take something, it's an approach, what we've used for, let's say, undiagnosed infections, such as underdiagnosed infections, such as influenza or viral hepatitis or even COVID-19. We start with those underdiagnosed estimates and we apply correction factors. And this could be done in the case of overdose deaths to turn a number of reported deaths, for example, with various correction factors into the total number of overdose events. There's other types of scaling methods, such as the scale-up methods, where we conduct surveys in a community about attending a certain venue. And if we know how many people went to that venue in a year, we can sort of back into a population size estimate. Other methodologies include what's called multiple systems estimation or capture recapture methods, and that's really based on ecology methods such as tagging wildlife or fish in a pond, where we look at tagging, releasing, and recapturing a population to estimate the population size. But in the case of the populations we're interested in, this might be the captures are actually looks at different administrative databases where substance using populations may be found. A well-known application of that has occurred with some great studies in Massachusetts. And this is increasingly being thought of as a gold standard type approach, but there's real key complexities. And I think we'll hear about maybe some of those today in terms of the data requirements and the analytic requirements, right? This methodology requires individual and identifiable data to be linkable and often across very different agencies or organizations, which creates many challenges. And the ideal is that data are generated from independent processes, but in practice, that can be quite difficult to have truly independent data sources. And there's methodologies to deal with that. And I'll say finally, there's also, of course, simulation models themselves where we construct a representation of reality based on a variety of inputs, try to simulate life or life as best we can, and then project the number of persons or health events such as overdose of interest. So that's just a quick snapshot, at least from my head, of sort of what are some of the key sources for this information when we're talking about these estimates among hard to reach populations. But I want to get to our speakers. And in their remarks, we're going to hear about a variety of things. We put 3 questions to them, and to sort of help seed their remarks. One was really to comment on the sources that they turn to for understanding the sizes of substance using populations and the occurrences of overdoses in the areas that they serve. And so that's the first question. The second was to think about and talk about how they use these kinds of data to inform the allocation of programs and resources in the areas that they serve, and including setting targets and monitoring progress, and also just generally inform the situational awareness. And then, of course, an important consideration for modeling and epidemiologic work is that no estimates are perfect, particularly for hidden populations and behaviors. And so, and this in turn limits the ability to generate, so I'll just say, no estimates are perfect and there's going to be trade-offs. And there's some specific questions that we ask them to address around what kind of trade-offs do they make in terms of the data they consume, and what kind of basically what kind of trade-offs are they okay with? For example, would you rather stratify something by geography or by race ethnicity, knowing that you can't have both? And are there any priorities around sort of the levels and ways in which they consume data that they could feed back to us in the modeling world to inform the work that we do? So with that, I want to hand it off to our first presenter, who's Dr. Amanda Slaunwhite. And she's the scientific lead for the Provincial Overdose Cohort at the British Columbia Centre for Disease Control. Dr. Slaunwhite leads an active program of research that uses administrative health data to examine topics related to overdose, substance use, and geographic health inequities. She also leads projects that use community-based participatory methods in the areas of peer support, substance use, and community reintegration after release from correctional institutions. Dr. Slaunwhite is also the co-PI of the University of British Columbia Research Excellence Cluster in Transformative Health and Justice. So please take it away, Dr. Slaunwhite.
Thanks so much, Eli, and thank you so much for having us, and good morning, everybody. So as Eli said, we were provided a series of 3 questions, and I'm hoping to touch on all of them. The first being around what sources do we turn to for understanding the size of substance using populations, and then also how do we identify overdose events? So I'm going to start with the size of substance using populations. And historically in Canada, I think we've really relied on surveys administered by federal organizations like Statistics Canada to get a sense of the prevalence of persons who are using substances. However, these have become of limited utility over the past few years, and especially in the context of the overdose crisis in Canada, which is primarily led by or driven by illicit substance use. And in those surveys, they do not ask about illicit substance use. So that is a huge limitation of those existing methods that we have used in the past. A second major source, and a source that most of our work at the BC CDC draws on, is administrative health data. And this includes data from emergency health services, including ambulance services, hospitalizations, emergency department visits, and visits or billing from physicians. One of the major components of that is that we are relying on persons who use illicit substances to interact with healthcare in order to capture them. And unfortunately, we do know that many persons who use illicit substances experience harms to their physical, mental health that lead them to seek healthcare services. And so by having a broad array of healthcare service data that we can draw on, we can capture many of the overdose events. It is helpful, the admin data is really helpful for identifying cases where substance use has led or is contributing to an acute event, but we do know that it is not representative of everybody who uses substances, especially with the stigma associated with substance use. Many folks abstain from seeking healthcare services, even perhaps when they are really needed. And so we know we are missing many persons who use substances from our administrative healthcare data. So we have two kind of imperfect sources of data that we have used in Canada primarily. The first being survey or self-report data, which is has its own limitations because we're requiring that people self-report, and on those surveys that are provided by the federal government, often they may be done at the household level, and people may also not want to report their substance use, and also the exclusion of illicit substances from those surveys themselves. And then also admin data, where we know we are really capturing those really acute cases where healthcare is required, but we know that we're missing a lot of folks. Moving to overdose. In BC, we primarily, and I'm going to focus on non-fatal overdose. In BC, we primarily rely on data from ambulance or emergency health services to identify non-fatal overdose cases. So in the provincial overdose cohort, approximately 50% of our non-fatal overdose events come from ambulance data. And this is really important because ambulance data is not collected federally or sometimes even provincially, depending on where you are in Canada. It is not often used for this type of research. It's a new type of data source. It became available in BC as a result of the 2016 Provincial Public Health Emergency Declaration. And so the data that we have at the BC CDC from Emergency Health Services is very unique, and it is only available through the BC Provincial Overdose Cohort. It is stewarded and governed in a unique way because of how it became available to us for analytics and surveillance. A second major source for us has been emergency department data. In Canada, this has been primarily collected through NACRS, or the National Ambulatory Care Reporting System, that CIDE often rolls up and creates national reports. Just a caveat on that, though, is that we know that NACRS excludes smaller hospitals, non-trauma-based hospitals, and we don't have complete coverage with NACRS in BC. And so as part of the overdose response and the surveillance activities at the BC Centre for Disease Control, we have set up an enhanced emergency department surveillance system in 3 of our most rural and remote health authorities. And so whenever somebody walks into it or presents at an emergency department in Interior Health, Northern Health, and Island Health, a physician does fill out a case reporting form that is sent to the health authority, and that is sent to us, and we can do data linkage based off of that. But without that system, we would be missing many overdoses that were occurring in these communities. I guess a caveat on this that I would like to say is that from our experience, the emergency health services data, the ambulance data, these are really unique data sources that have been critical for identifying over half of the non-fatal overdose events, and they aren't commonly used. And I really do think that this puts into context that if researchers are relying on hospitalization or national level ED data to really specify that and to put your results into context, because we know from our data that you are very likely missing over half of the non-fatal overdose events in the population. The third question that Eli had for us was around allocations of programs and resources, monitoring progress, etc. So just to be clear, I do not make those decisions. I am a senior scientist. I don't allocate programs or funding, but all this to say that the data from the provincial overdose cohort is used to allocate resources in the province, including federal treatment funds, overdose response funding and resources that are being distributed across BC, as well as to allocate or determine where to establish community action teams or even overdose prevention sites. We are really integrated into our provincial overdose emergency response center. So every piece of analytics that my team and I do goes to the overdose emergency response center, and it is used for policy and practice. Having a reliable and trusted estimate of the number of persons who are at risk or are using substances that might be at risk of an overdose has been really critical for understanding the scope of the reach of current interventions. So in some of the work that Dr. Bohdan Nosek and his team have done, as well as some work at the BC CDC, we do have some reliable estimates on the number of persons in BC who have opioid use disorder. And this is really critical for determining the scope and the spread of interventions and the uptake of interventions and how many people are, for example, obtaining prescribed safer supply in the context of the population at risk of overdose. And so they are really critical for understanding how these interventions are affecting the population. And then the fourth question around trade-offs. So this isn't a trade-off, but I wanted to mention it that I think it is a reality that we need to confront, which is that in Canada, First Nations and Métis Inuit data on Indigenous identity it needs to be governed and stewarded in a responsible way that meets the principles of OCAP, as well as the Truth and Reconciliation calls to action. In our data at the BC Centre for Disease Control, we work really closely with the First Nations Health Authority, as well as Dr. Bohdan Nosek and his group in the work that they do. And the data on Indigenous identity is completely governed and stewarded by the First Nations Health Authority. And I think this is really important to consider because it not just affects Indigenous people, but it also affects potentially how we identify race or ethnicity. I have seen methods used around name-based algorithms and whatnot, and we need to consider that those algorithms could result in the erasure of Indigenous identity. And this is really important in the context of Indigenous peoples being disproportionately affected by overdose. We know that in our cohort, upwards of 20 to 25% of people who've had an overdose are First Nations. And so we really need to think carefully and thoughtfully with those communities around how we define race, ethnicity, and then also Indigenous identity. A trade-off we have accepted is around the reliance on admin data means that we can't really get at substance type. So when somebody presents for a non-fatal overdose, the physicians and the healthcare staff don't necessarily know what they took. They don't know the composition of those drugs that they took. They do know if they responded to naloxone, it's likely an opioid, but it becomes more tricky when you have other substances, especially benzodiazepines. And I think I have seen some work done in this area, and I think we need to think really carefully about our trade-offs and why we think this data is important and how is this data useful to overdose response efforts. So that's really how we think about our data at the BC CDC is how can this data be used to inform overdose response efforts and to reduce overdose in BC? And I do think that we need to think about what is the value add of doing deep dives into toxicology, especially around an illicit drug supply that we have zero control over. And we have very little insight into how drugs are manufactured in Canada because it is criminalized. I will also say that a limitation we have accepted is that we really do not know the true number of non-fatal overdose events that have occurred in the province. So BC has been leading in terms of the distribution of community-based naloxone. And we know through the work of Dr. Jane Buxton and the harm reduction survey that 911 is usually called in around 56% of cases where a bystander is involved in the overdose. This is probably lower, so less than 56% of people are calling 911 if they are regular drug users and feel like they can respond to the overdose event in that context and they don't need healthcare. And so we have accepted that we know we're missing likely half of non-fatal overdose events because 911 isn't being called. And I think that we need to understand this a little bit more. And I will just say that at the BC CDC, we have a project right now that is looking at modeling the true number of non-fatal overdose events that are happening relative to those that are seen in healthcare and those where 911 isn't called. And I think that's going to be really important for understanding the true number of non-fatal overdose in BC. Quickly, some additional trade-offs. I really believe that granular spatial data is absolutely required. I think it's in the data that we have latitude and longitude. It's very, very granular data, and we have done some spatial epi work with that. And we do see big differences in terms of overdose outcomes across different geographies. And so I think the more granular the spatial data you have, the best. Housing data is helpful, but it's important to keep in mind in the work that we've done, we've seen transitions are really important to overdose, and housing status can change week to week, month to month for people. And so I would think really carefully about that housing data and to not have a dichotomous kind of homeless or not homeless kind of variable. And then also incarceration data has been very important for us in terms of modeling overdose risk over time as people enter institutions that are less likely to overdose. And I know I'm probably running out of time, but I do want to have a quick plug that in a call kind of for action, I guess, that some key questions that have come up for us recently and things that we've been mulling over is around the potential to do micro-targeting of surveillance. So in BC, we've had a lot of questions around the long-term impacts of having many non-fatal overdose events, especially on brain injury, anoxic brain injury, and neurological health. And this is something that I'm really keen to explore, is around how can we micro-target surveillance to create weighted representative sample estimates to look at the long-term impacts of overdose on population health, which we really do not have adequate data to address that right now. So that's a lot. Eli, so maybe I will stop and leave it to the other panelists. Thanks.
Yeah, that was a lot, but it was rich and gives us lots to think about and talk about in the discussion afterwards. So thank you. Thank you for that. I'm going to now turn it over to our second panelist, Dr. Angélica Ospina-Escobar. Dr. Ospina-Escobar is currently a research associate professor in the drug policy program of the CIDE-Central region in Mexico. Her research focus areas include populations and health, particularly problematic drug use from a socio-demographic and life course perspective. Dr. Ospina-Escobar is also a founding member of the Mexican Network for Harm Reduction, also known as ReduMex. She draws on more than a decade of research experiences, providing guidance to community-based organizations on monitoring and evaluating data on harm reduction programs in northern Mexico. So with that, I'm going to turn it over to Dr. Ospina-Escobar.
Good morning, everybody. Thank you so much for the invitation to join this amazing panel. And thank you for the opportunity to share with you some thoughts about the data gaps that we face in Mexico for having an accurate overdose estimation. And I apologize in advance for my bad English, and I really, really appreciate your patience with me. I prepared a presentation, so it can be easier for me that way. So let me, okay, that's it. So in terms of the estimation of opioids, can Can you see my presentation now? Yeah. Okay. In terms of the estimation of opioids using populations, we have like two different exercises, like nationwide exercises and more specifically situated ones. At the national level, the main source for the estimation is the National Drug Use Survey, which is called OUD, and is a household survey and is collected every 5 years. And since 2008, the survey reported a national prevalence of opioid use of 0.2%, which means that there are around 140,000 people who use opioids around the country. But mainly they are focused on some states of the country, no? Then in 2010, CIDE, which is the National Institute for HIV Prevention and Control, conducted an estimation of people who inject drugs in the context of the Global Fund project. And they use the HIV surveillance system and the National Drug Use Surveillance System, and they got very similar estimations of population who inject drugs. And they in that time, they got 150,000 people who inject drugs. And those are the data that we have for this population. And then we have more specific exercises in some cities. For example, in Ciudad Juárez and in Hermosillo, Sonora, some studies have conducted capture and recapture exercise. And in Tijuana, as I know, they have made estimations using community-based surveys, and usually the outcomes used to be the same at the national level, you know? So the interesting thing in Mexico is that we don't have a generalized opioid using phenomenon, but is very focused on some cities. Ciudad Juárez, Tijuana, Hermosillo, and Guadalajara are the four cities with the larger opioid using populations at Mexico. And then we have the data, the available data for overdose events. We have the vital statistics, the mortality records, hospital discharges, and emergency room. Unfortunately, the ambulance data are not publicly available, and we don't have data from prisons. Let me show you how does the mortality data look. And as you can see, besides the bad quality of the data, the first thing to say is that from 1998, from 2018, there were reported only almost 200 deaths, no, in almost 2 decades. No, that's one of the findings, which is the number is very low. And the second interesting thing is the green line shows the moment when the fentanyl arrives at Mexico. No? This is the time when the first seizure of fentanyl is reported, and we can see an increasing trend in the rates of opioid-related deaths. No? And then we have the hospital emergency. This is the people who are taken by the ambulance and are taken to the hospital rooms, no? To the emergency rooms, excuse me. And we can see the same trend, the same increasing trend since the arrival of the fentanyl to Mexico. And in total, from the last 10 years, there are almost 4,000 opioid use-related emergency, which are quite low, as we can see. And then we have hospital discharges. This is the people who were admitted at the hospital. No? So this is very selected population. And here the trend is more tricky, but you can see that from 2015, we can see an increasing trend. No? And we only have 1,500 records in the last decade. So in the summary, we can say two things besides the bad quality of the data. One is about the low numbers of the data. No, we have only like 19 annual opioid use related deaths and about per year, and we have like 972 non-fatal overdose, and that's very low compared to the experience that we face in the field. For example, in 2019, Fleece and colleagues reported that around 60% of people who inject drugs have had experienced overdose. And among them, they reported having had an overdose almost once a year, no? 1.6 per year. So it means that we could expect having around 90,000 records of non-fatal overdose, but our records, our official records, just show 972. So are the official, this is a question, no? Are the official data reporting only around 0.01% of the total overdose events that are actually taking place in the field? And trying to understand why this huge underreport, we have to analyze the conditions of the people who inject drugs in Mexico. And we have to say that many of these people live in conditions of extreme marginalization. For example, 60% of them do not have official ID. And if you don't have an official ID in Mexico, you can be admitted at the hospital. So that is the first like barrier to be in the record. And on the other hand, most of people who inject drugs reported that they prefer to be assisted by a peer and not to call an ambulance. First, because of the stigma and discrimination that they feel in the health facilities, but also because most of the ambulance do not have naloxone with them, because in Mexico, the naloxone is over-regulated. I can talk about it later. So as they don't get to the hospitals, to the health facilities, these events are not being properly recorded. There are no way to record those events. And when they die, their deaths occur in shooting galleries and public spaces where there is no medical doctor to sign the death certificate. And in the field, we have found that many overdose deaths are registered as heat stroke. We call it golpe de calor in Spanish, by the police to avoid the paperwork. No, so even though there are no way and if you take into account that they don't have no identification, that they live in the streets, so there are no way to collect data from these people that are invisible. So besides that, in Mexico, there are no good Samaritan laws. So at the moment of the death, there are no one who can provide proper information about the cause of death. And when the bodies get to the morgue, the toxicology tests only are run if an authority requested for it. So most of the autopsies do not run this test. And last but not least, the cities with the larger opioid users populations are also cities with high rates of violence, where the morgues used to be collapsed. And this situation limits the proper examination of the bodies to verify to verify overdose as a cause of death. In this context, it is important to have like a humanitarian strategy for the registration of overdose, trying to join the government efforts with the civil organization efforts. So last year, with the drug policy program and Programa Compañeros, we ran an exercise to register the overdose events, fatal and not fatal, that took place in this city. And Programa Compañeros is a harm reduction organization, and they have a program for naloxone distribution in shooting galleries since 2018. So we use their experience, they train peers, etc. And the interesting thing is that the official data report 29 opioid use-related deaths between 1998 and 2018. And we recorded 17 opioid-related deaths only in 2020. No, so we can see the huge gap in the comparing the official report with the community-based report. And this is the map when the where are located the shooting galleries, and we also collect data about the characteristic of the people who experience the overdose, gender, the substance use related with the event, and as you can see, this information is timely, is geographically coded, so we can say where are the deaths or the events taking place, and really helps to inform where to allocate the resources, for example, in a local context. So finally, to say, having a communitarian strategy for overdose registration helps to have a timely response to local overdose crisis. The official records are 1 year delayed, so they not help us to allocate any resources. And honestly, I think the government are not using this information because there are no proper harm reduction program in Mexico. This communitarian strategy could help us to have better information about the specific characteristics of the overdose events at the local level. For example, what happened with the gender differences, what happened with the substance use combinations. Each city has its own specific dynamics of drugs dealing. For example, Tijuana is very different from Ciudad Juarez, and we could see that the main overdoses in 2020 in Ciudad Juarez were related with alcohol and benzodiazepines, I don't know how to say, benzo pills, combined with heroin, and not necessarily with the fentanyl exposure. Anyway, and also having this communitarian strategy for registration can set early warning system to prevent overdose death. So this is like the call for action, and I thank you for your attention and your invitation again.
That's great, thank you, Dr. Ospina-Escobar. That was really fascinating and just gave me a lot to think about, and because compared to our experience here in New York, which is just so different, obviously, in terms of the legal frameworks and the systems, and just to hear that perspective just over the border is fascinating. I look forward to talking more about it. After our third presenter, we're going to have a more open dialogue. And our third presenter is Dr. Allan Clear, who's worked in the field of drug user health for a long time, since 1990. Allan was the executive director of the Lower East Side Harm Reduction Center, one of the first syringe exchange programs in New York State, and of the Harm Reduction Coalition, which is a national organization, a prominent community-based organization that advocates for harm reduction. And currently, he is the director here in New York State Department of Health at AIDS Institute's Office of Drug User Health, where he's responsible for overseeing program planning, design, and implementation related to drug user health, which includes overdose, HIV and Hep C prevention, and access to care. So Allan, I'm going to hand it over to you for your remarks.
Thank you very much, Eli. And yeah, just to confirm, I am not a doctor.
Yeah, I conferred it on you in the moment. I'm sorry.
Yeah. I'll be the variety, which makes me a bit of an outlier. And I will come from more of a program perspective, I think. Well, I will. Not thinking, I will. I was thinking back, like 1988 was pretty much the year that syringe exchange program started in the United States. And at the same year, the federal government put a federal ban on the funding of syringe exchange or the purchase of syringes. That ban still exists, however many years later that is. It's nearly 30 years or whatever it is. I'm not a mathematician either, not at this moment. So it's like, despite the data, we don't have necessarily the will or the political will to actually work with people who use drugs to actually solve problems that they might experience. And we've deliberately, the US has always had this process of harm maximization when it comes to drug use. And that's softened in during the overdose crisis because it impacted white people. And therefore, we realized that some of the white people impacted were not bad people. And therefore, maybe we should change our approach, which is sort of the American sickness, isn't it? It's an inherently racist society. So what I was thinking about COVID in New York State, as you all know, it hit us hard, hit New York City really hard. And yet we were able to mobilize forces within New York State to address COVID problem. We could put up pop-up testing sites. We could suddenly put resources into communities that where there was no healthcare before. We could do testing, we could do vaccinations, we could do things we hadn't done before. We can invest in it. And that's not what we've done for people who use drugs. We just haven't. But we saw under COVID that we can do it if we have the will to do it. So that set, I wouldn't say it was set me off thinking, because I've been thinking about this for a long time, but it confirmed, let's say, that the strategies we use to treat another epidemic could be applied to what we do around opioid overdose or drug user health in general. We do use, I would love to have the data. I would love to know how many people use drugs, however we define that, however many people we have use drugs in New York State. But I don't know what we would do with it, because data in and of itself is this pure thing, and science is sort of this pure thing, but it's muddied by politics, it's muddied by media, and it's muddied by resources. So we do use data. We have CDC funding that we use to support 24 local health departments in New York State. We used death data from the Bureau of Vital Statistics. We use CDC Wonder data, and we use Sparks data, which is emergency department hospitalization data, to pick those 24 health departments. And that's how we chose to work with those counties and build the capacity and provide technical assistance to help them address opioid burden or overdose burden in those counties. So it's not like we don't use data to implement programming. What we don't do is we have no mobility, no nimbleness. Anything at the government level takes too long. Eli works for the state now, and I probably shouldn't say any of this stuff anyway, but it's like, if you look at people ask me what's going on in our county, whatever, and I don't even want to point them to our own website. The New York State resources are out of date and fairly pointless unless we use real-time data and use that real-time data to actually respond to something that's in the community. We're not really, that's the only data that has value to me as someone who's implementing programming. And the barriers to implement that program is so extensive, we can't act nimbly. But that said, as I mentioned, COVID, we are trying to develop a more rapid response to address overdose problems. And I think that the fact that we see more fentanyl in stimulants now, we saw, I think, 24 people overdose on crack cocaine. That's what they thought they were using, and they overdosed. In the Albany region, sometime last year. And yet we had no response to that except to let everyone know that this was happening. And what we're working on now is how to get boots on the ground in responding to real-time data. We don't have access to EMS data. I wish we had as an English person, I really wish we had a data source that was called NACAs here in the United States. But we don't have anything with that kind of fruity label. One of the things we have done, which caused us a great deal of angst, is use police data. Police data is not HIPAA, it's not medical records that are protected. We use that in New York City. We get information from NYPD, which is mostly incomplete, very often inaccurate, because what person who uses drugs is going to give up a lot of information to the police department if they're waking up from a non-fatal overdose and someone asks where they live. But we do follow up on all of those because it's not medical information that's protected. And we we call, we make home visits. That's real-time data, and we get that data every week. And our team goes out and tries to connect with the folks that are impacted there. We're honing that in too to target hardest hit neighborhoods in New York City, as opposed to trying to cover the whole city, because the impact of overdose is not equal. It's not an equal burden. And certainly the Bronx needs a much greater share of our attention than other areas of the city. We use our harm reduction programs as sentinel sites, really. We sort of triangulate triangulate. We do use syndromic surveillance, and I do respond to that. We get spike alerts on a regular basis. And that's when I can reach out to some of the harm reduction programs who very often know before we do what's going on. I've had an instance where we had a number of overdose on Long Island, went straight to the program. The program knew who was dealing the drugs that was causing the overdose, and had already spoken to the dealer to get their supply off the market. But again, we're stuck with this even with real time, what can we actually apply to it without the resources and the political will to invest in the lives of people who are being impacted? What else do I have here? Drug testing. We're very interested, like everyone else, or maybe not like everyone else, but we are very interested in testing the drug supply. But as Dr. Slaunwhite said, it's like you can test the supply, but then we don't have control over the market. It's a contaminated market. It's an illicit market, and until we are in a position where we regulate that market, we don't have any say-so over how those drugs are, the purity of those drugs. But it's also what we tend to do is get our information from the dead bodies of people who use drugs. And we don't do that with any other outbreak or poisoning problem. And yet we seem to be okay with that when it comes to people who use drugs. I think the compromise piece is such that we don't know. I mean, what we saw in the COVID, let me step back a bit. What we saw in the COVID is that people who were experiencing fatal and non-fatal overdoses were people not known to us. As I mentioned, we use our harm reduction programs. There's 25 of them. They have over 80 sites around, or over nearly 80 sites around the state. So they're quite, it's quite well spread out, and there's a lot of information that comes back to us. But what we were hearing from our programs is that the people overdosing were not people that they knew about. These were people, maybe they were people who had picked up again. Maybe there was something with the fact that there was social isolation that made people pick up or use when they wouldn't normally use. But we weren't in contact with those people, and that's a population that We need to reach and we need to understand better, and we need better communication, we don't have the data to support what we need to do. We don't, and I'm not even sure we need the data to do that. We need some kind of educational campaign, but our programs were providing a protective factor. They were, if our people were not dying and the people who were known to the programs were not dying, there's a protection there, which means we're doing a really good job on the ground in those areas where those programs are. So when it comes to like the compromise to me is using data around, we're on the verge in the United States. We've been on the verge for a number of years of opening overdose prevention sites, which it's incredibly frustrating. As someone who's worked in syringe exchange for a long time, it's another service. It's not some dramatic, radical thing to provide a space for people to inject. It's just not. And yet we blow it up as if it's some radical adventure that's pushing the limits of social behavior. But the fact that we don't have them, well, I won't go there. But it's like the location of those places, that they've got to be in high density urban areas, because the only people that will use, the people are not going to travel great distances to use them. So they're not going to work in rural areas. So as someone who works for the state, our interventions need to be broad-based. We need to provide access to what in the US would be a safe supply, would be easy access, low threshold buprenorphine to people living in rural areas, so they can get hold of medications that can keep them alive. I think I'm probably at the end of what I have to say, and looking at my notes. Yeah, I think I'm probably at my 10 minutes, if not more. So I will pause there after saying what I had to say. Thanks.
Thank you, Allan. That was great. I feel like we actually just got in our three speakers a really diverse set of presentations, not in terms of both the geography served and the population served, and the sort of the constraints or differences in those environments, but also just sort of the levels at which each of the three of you are working at and the perspectives that you're coming from. So that was really great. And there's a lot going on in the chat too. So I'm gonna have to try to I want to ask some questions, but I also want to be able to keep up with the chat and sort of try to bring some of it back for discussion, because some of it's internal chatter, but some of it I think is also good for broader discussion. And I'll just pick. Actually, I might just pick on one. Might even start in the discussion in the chat. Just pick on one thing that I think is an interesting point, which is, Allan, you brought up several examples building on what's happened during COVID in terms of the type of response that was able to be stood up when there was the willpower and the resources put into it. And Josh Berkus, I think, initiated this thread around, well, we have daily COVID data, right, and various trackers that are everywhere now, and and Allan, you spoke to sort of the importance of real-time information. Annual reports from 2 years ago aren't so helpful in combating the drug epidemic today. And I've thought about this issue a lot myself. I'm sort of one of the folks in charge of redeveloping our COVID databases, data pages to always be more real time and accurate and better. And we're trying to think hard about how do we in New York, how do we extend the COVID model here for putting out data all the time in a way that is useful and important in other areas, while not giving ourselves too much of a burden and making things too real time available. There's a lot of effort that goes into that, and of course, data quality can suffer the more real time you put information out. Not COVID data that goes on the internet daily is not necessarily accurate daily, and there's a lot of data quality issues that go on that are in data sources across jurisdictions, and there's something to be said for a clean annual data dump. So I think there's room for improvement here. So I'd be curious what you thought, what this group had to say about sort of efforts to improve the timeliness and public reporting of information, though, and I'll state my last thought is that, Allan, you brought into play a number of data sources that are sort of internal data sources that you have access to that guide how you can respond in more real time, even if they're not necessarily public sources. So I'll just leave that comment there, but I think that's a really important area for discussion. I'm curious if any of the panelists had any thoughts on that.
I think so. In BC, our BC EHS, our ambulance data and our coroner data is received quite frequently, usually every 3 to 4 weeks. And I think that given all of the agencies that are involved, as well as the delays, especially around filling in missing identifiers and things like that, I think it's well ahead of where other provinces are. And I think it's quite sufficient for identifying regional trends, but the surveillance data is important for understanding what is going on. But I feel like also the input of peers and like the drug alerts and things that are happening through the health authorities, that is coming from additional data sources. So I really think a combination of data is needed. I don't know if having daily counts of overdose event would really illuminate any additional insights into what is happening.
It's important, right? So, and I struggle with this because sometimes daily reporting is just not the answer, and I struggle with trying to convey this to people, even in the COVID space, that looking every day at a phenomenon doesn't necessarily give you more insight. And so I think it's really important. And Josh, you're raising your hand, right? So please feel free to jump in. You've been very active in the chat too.
I really appreciate that last comment, and thanks, Eli, for calling on me. I didn't know if I was allowed to talk. But Amanda, I think that's the point you just hit on is so important. It's not just about the sort of usual data sources that we think about. And going back to Allan's comment about, what's different about the response, looking a little bit holistically, we initially, aside from mobilizing the healthcare system here, at least here in the US, like I can't speak to everywhere, but at least mobilizing the healthcare system, we also treated this like an emergency, right? We treated COVID like an emergency that it was. We set up central command centers and involved not just like the usual players, we involved people in the community, and that same emergency response system hasn't been set up. And I wonder if jurisdictions, and I'm not pointing my finger at government or anyone, I'm just saying, I wonder if jurisdictions were to set up incident command centers where they actually involved people from various aspects of the community, people with lived experience all the way through, public health officials, if we wouldn't be able to set up a more real-time system where we knew what was actually happening and decisions could be made essentially in real time.
Josh, that's a good point. And I feel like the previous decade has seen lots of community-based attempts at such things, different county level councils that meet monthly or city level planning groups, with bring in different, stakeholders, review the data, talk about what needs to happen next. Are you thinking a change on that kind of model?
I think putting it more, framing it more as an emergency, because when we have emergency response systems set up, the incident command, for instance, it's not like, let's take our time and figure out and review the data and get all the voices. It's bring everyone together. We have to know what's going on. I mean, we're looking at literally a public health emergency, and we're not acting like it. In the same way that we acted like it when we had another public health emergency. And there are lots and lots of reasons behind this that we don't have to, that I think everyone on this call knows as to why some of these responses have been different. But at the same time, at the end of the day, whoever we is, the royal we, are not treating this in the same emergency, as the same type of emergency that we would if it were, COVID, if it were a hurricane, if it were a mass casualty situation, which is literally what we're dealing with, is a mass casualty situation, and we're not calling it that.
Angelica, did you have your hand raised?
Yes, I would say that in Mexico, at least, the overdose that I would say are mainly focused on marginalized people, and that could explain why the response is so low and so unarticulated. And on the other thing that I would say is that the importance of have these local committees for understanding what is going on. Because the dynamics, I already said, but I have to insist on it, are very different from city to city. And even the drugs, the substances that are available in each city are different. And also within the same cities, they vary from one zone to another. So having this kind of committee to understand what is going on, help us to enhance the response, and also build the capacities of the organizations that are already in the field doing and trying to address the problem that the government is not. And as we don't have data, it seems that there are no overdose problem in Mexico, so there is an urgent need to make visible the cases and to say, yeah, people are dying. It's people that do not matter to anyone, but are people dying anyway. And the other thing is how to not burn the organizations that are already working with very few resources, and how to conceive the peer workers, the peers work beyond the programmatic thing, and how to involve them in the enhancing of the data system as well, because they know a lot of things. They have lots of abilities than we, the people who work with the data, used to do not take into account, and how to integrate the peers in the whole understanding system thing.
Amanda, your hand raised.
Yeah, so I think that the provincial public health emergency has really helped, like the viewing of overdose as a public health emergency in BC, and it did give additional authorities to the provincial health officer and the regional health authorities around overdose prevention sites. But I think what is really important in the Canadian context is that some of the issues that we're talking about that really affect overdose, especially around safer supply and the federal drug laws, are things that cannot be handled by the province. And I think that's really the barrier where we are now, where the province of BC is requesting a Section 56 exemption for the province, that we're coming up against what is actually possible within the province itself, and that there are other levels of government outside of the province that have a key role in the overdose response, and then also around political will. So at some point, there needs to be these larger decisions made around decriminalization, access to safer supply and whatnot, and the political will really needs to be there to push those forward, and that really can't necessarily be done at the local level given our existing criminalization of people who use substances.
I see two hands raised, and I see Bruce and Zoe. So Bruce, want to go first? Then I'll go to Zoe.
Sure. I just wanted to point out in terms of the COVID analogy or non-analogy that pretty uniquely, the COVID response has included modelers, and modeling is part of the dialogue, partly because we so much acknowledge that we don't know things in COVID and we have to project it into the future. And so maybe this is something that people can talk about during the break in the chat. But I mean, we as modelers can, what is our role in that rapid response to the crisis that we're facing in the same way? So others should talk about what they want to talk about, but I just want to lay that groundwork.
Yeah, I think that's a really important point. And to be on a little bit of a soapbox, I haven't quite fully be able to articulate this here. But if I the role of modeling in COVID has been interesting. And if anything, I don't know if this is a fully informed thought, but I think the role of modeling has diminished during the pandemic to the point where we're not really looking or using models as much to make our decisions right now. And I think that also highlights, and actually I've been pointing out recently, we're entering an interesting phase of the pandemic where I think models would be really helpful, because I think there's a collective confusion about where to next with so many questions around vaccines and boosters and where's it waves and variants and where's this all going. The questions are getting complicated and beyond what we could easily comment on without models. And that to me is actually another interesting hazard of the emergency mindset. We've been in an emergency mindset for a year and a half, and the population's tired of us. But anyway, so I do think there's a little bit of a hazard with the emergency mindset, which is that if you don't solve the emergency quickly, it could lead to interesting things a year and a half later. Anyway, but Zoe, what was your question?
I actually had more of a comment about using data in terms of like timely data. Like I understand British Columbia called a public health emergency, but then they've seen like a massive increase in deaths during COVID. And here in Ontario, where I live, there will be 5,000 people dead by the end of this year. Over the last 2 years during COVID, an 80% increase in overdose deaths. We also get access to paramedic data, but it doesn't show us actually where the buildings are that people are dying in. We don't get to sit at the table with that data source and say, hey, we'd like to actually put interventions to that. So it really has its limitations when it's just being driven by certain levels of like policymakers and researchers who are not connected to the community. And then, I think also about calling it emergencies, like we've never called it an emergency. I mean, the reason why people are dying isn't stigma, it's just full on discrimination. We know from our data that the reason that the majority of people who are dying are homeless, they're people who are unemployed, they're low income, they're Indigenous, they're Black. Like we know that they're the most marginalized communities, but we also know there's absolutely zero political will, just like in COVID, to actually care about these communities. So we don't have an emergency table. We do not have coordination at our city level, despite the high rates of death in the last 10 years, despite the access to data, despite, lots of great people working here. I just get to watch the community that I'm a part of die. I've had 6 coworkers die over this last year. Talk about wanting to interact with harm reduction. Harm reduction has lost its workforce. We don't even talk about the harm reduction workforce. We talk about healthcare, but we leaned in to COVID, we leaned into the housing crisis, and we leaned in to the overdose crisis because we know how to respond in a crisis. We know how to not abandon people to die, but nobody speaks up for us. No researchers, I barely hear researchers say, I'm deeply concerned about people who use drugs and people responding during COVID, and people have a lot of political clout, have not used that during this time, as we've just watched like people leave our field and people die. So I just think something to consider, and I know I'm going to talk later on another panel where we'll talk about this, but just when I see like the stuff about data driven and like talking about Canada where we seem ahead, that there's like lots of issues to really clearly think about, and what we as researchers have a responsibility to.
Oh, thank you. No, that was great. And yeah, that was great. And thank you for, I'm really excited to hear your extended remarks in the next sessions. Next question is from Bodan Nozick.
Thanks for that, Zoe. And thanks for bringing up the the enormous amount of trauma that the community faces as a result of these overdoses. That is something that comes out every time we speak with people with lived experience. It's a huge factor that, you know, I just don't think we can really relate to the amount of trauma that goes that comes with this overdose crisis. It has a huge mental impact, and that's something that we need to consider and quantify in our work moving forward. There's another piece that I wanted to bring up on the topic of reporting. So frequency of reporting, I mean, that's one element. I don't think the argument for daily reports are as strong. I agree with Amanda on that point. This is an infectious disease. There's an element of social contagion to it, but it's a slower moving process. The other piece, though, is, you know, the severity of those overdoses. And I feel like maybe I've brought this up in meetings past. Is anybody collecting information? Because we're talking about this as if it's a homogeneous event, but we know they're not homogeneous, right? We know there are cumulative effects. There are different effects with repeated overdoses. There are different effects with the multitude of drugs that are detected, at least in toxicology reports. So, and we know there are downstream effects for more severe overdoses, right? So, and that's really, you know, we're talking to a bunch of modelers, a bunch of health economists. There are some serious downstream consequences that we need to consider. But I personally, I have not seen enough information on that for us to say anything meaningful about it. And I wonder if anybody at all has any information on severity of overdose and if any kind of work is being done around that. Amanda has some information on at least like the number of drugs that we're seeing in toxicology reports. You want to elaborate?
Yeah, I mean, I'm there with you, and don't tell me the Coma score is what we should be looking at, because obviously the Glasgow Coma score, which has been used in the past to look at or used as a proxy for the severity of overdose, is imperfect because people go in and out, and it really doesn't speak to the duration of the overdose and the amount of time where somebody is in an overdose state. But this is a huge issue in terms of the long-term impacts of overdose on population health, and especially around neurological health and brain injury. I'm there with you, Bodan. If anybody knows of any work that is being proposed or has been done in this area, this is a huge limitation and something that I think we really need to get to, especially around modeling the longer term impacts of the current overdose crisis on population health.
Those are really great points, and something that yeah, I've raised in other conversations as well, is thinking about overdose as not the only event, and as Bodan's saying, not, and it's not a binary, you know, did it happen or not event, that there's a spectrum to that, and there's long-term consequences. And we had to keep bringing up the COVID analogy, but we've seen this with other disease areas as well. There's a natural progression from worrying about the acute thing to the long-term consequences. Right, and do we need to, right, what we're hearing here is a need to move the data conversation beyond the acute events to really understanding the full range of health impacts. I think that's really important. And Ayaz, you've had your hand patiently raised. Your turn. And I mean, this might be our last question for the session.
I'll try and make it quick. So, you know, we've had a lot of experience with real-time dashboards around opioid overdose surveillance. And I was wondering if any of, because this is a conversation with modelers and others, and I consider myself a modeler as well, I'm wondering what your thoughts are on how modeling can be incorporated within these surveillance dashboards that exist in some places, and specifically short-term modeling. So not, you know, long-term or years, but in the next month or 2 months or 6 months, if a treatment provider leaves a certain area, if, you know, certain types of strategies or the level of stigma increases in a certain community, how can we potentially, or are there examples from all of you, the panelists, where you have seen how you could work with multiple stakeholders by building, but also then using those models that can consider those what if scenarios to convince them for short-term investments and strategies.
Any of our panelists want to take that one?
So we do use some modeling in our dashboards to estimate what we think is going to be the outlook for like the next 2 to 3 months in terms of overdose. And I think that is helpful, but it always goes up, it never goes down. And I think it's of minimal assistance in terms of decision making, but I'm willing to be told that I'm wrong.
Well, thank you. And with that, I think we're at time. And I didn't have to pull out any of my emergency questions to, in case this was a silent group, because you were not, and you're vocal, and you've raised a lot of really great perspectives. So I think I'll hand it back to Natasha. Is that the right order of baton passing?
Sure. Thanks, Eli.
Great.
And thanks, everyone.
Yeah.
Thanks, Eli, for chairing, as well as all the fantastic panelists and the people participating in the discussion. So I believe right now we have about a 15-minute break. So the next session will start at 2:15 p.m. Eastern, and that panel is on engaging people with lived experience best practices. So see you in 15 minutes at 2:15 p.m. Eastern time.